I'm really excited to be presenting right after Luke. It's always hard to go after him. He does this so effortlessly. He's able to sort of go back and forth between the board. He's able to talk 3 feet from the microphone and actually get the work done. And so I'm going to build on a tiny little piece of what he did. He really sort of brought us to 30,000 feet and looked down on implementation science and really sort of laid the landscape for where we are today. And I'm going to sort of narrow in just a little bit on one part of that. So there's not any exact 5 steps or 4 steps to implementation science, but you heard about the pre-planning and all the other sort of steps. So, goal setting, clarifying your vision, really defining the problem, identifying the barriers, and doing all of those sorts of process mapping and things like that. Really analyzing and gathering your baseline data so that you understand where you are and where you're starting. And then, of course, what I'm going to focus on a bit today is really on formulating a strategy, getting the right strategy. And I will say parenthetically that we don't always get the right strategy. We sometimes think that we have a barrier and we have a misconnection between what it is that we plan to do and how we're going to attack that. So sometimes we have to rethink what we're doing and tailor what we're doing. But we also sort of need to understand what are the existing resources, what are the alternative plans that we might do, and do we need, if we've got multiple barriers, and I'm going to present a slightly different version of the socio-ecological model, but do we actually have to plan for implementation strategies at several different places at once? Because it's not like you can necessarily say that one barrier is going to be more obstructive than another. We think that we know that, but we don't know until we get into the field to do that. And then, of course, there's the implementation of the strategy, making sure that we're clarifying the role of who's doing what. And then, of course, to evaluate and control. And so what we're going to focus on just today is this part around, the implementation strategies. So the question is what are they? And in this presentation, you're going to see another black box. There are lots of black boxes out there. And part of the reason for why I think that that's the case is that even though Luke brings us back to the diffusion of innovation that's 60 or 70 years old, the science of putting together the pieces as we know it today is relatively new with regard to sort of bringing a scientific approach to this. So implementation strategies are the actions or activities taken to increase the adoption, implementation, or sustainability of an evidence-based program, intervention, or practice. So the what we're doing is the evidence-based practice. It might be pre-exposure prophylaxis. If you happen to be in the behavioral health field, it might be a selective serotonin reuptake inhibitor. It is what we are doing. What we're focusing on with implementation strategies is how we do it. And, one of my favorite people to quote is, Einstein. And Einstein, for those of you who are in the behavioral field, he really said that that insanity is doing the same thing over and over again and expecting a different result. And really, where you are when you begin to do your implementation is you are doing what you know how to do. And if you have an implementation gap, let's just say that there's 100,000 people with HIV, and there's only 50,000 of them that are diagnosed, that's a big implementation gap. One of the ways that we think about where we're going to do this work is really identifying where those gaps are. So often we really try to implement and try to improve things where the gap is this small, and there's not going to be much of an effect when we try to work in that space. So really understanding what's really important. So we're doing the how. So the activity might be antiretroviral therapy, pre-exposure prophylaxis, serotonin reuptake inhibitors, but it's how we get it into and to the places where people can actually use it. And I will say that because there are oftentimes multi-level barriers, we often have to sort of combine these implementation strategies or bundle them, often with a package of them. We'll talk a little bit about it, some of the sort of mixed methods, mixed approaches to doing that, in order to really sort of think about what to do along the socio-ecological model. Now, there's a number of types of implementation strategies, and I will say that in some trials, where they compare a single versus a combination implementation strategy where you're working on maybe two different levels. Sometimes a single implementation strategy works out just fine, but systematic reviews generally suggest that you're more than likely to have to use more than one. But a discrete strategy is a single action or a process. That is, you can institute a group of, a set of reminders. You can provide audit and feedback. So if you have clinicians who are supposed to screen 100% of their patients, and you go back and you look at the data and they've screened 50%, you can point out, oh, you've screened 50 patients. That's great. What can we do to move to 60, et cetera? So you give them some feedback. What did you do last time? What can you do next? You can really provide educational sessions if there are sort of educational limitations, or you can have a workshop. There's a number of different ways, and we're going to get right back to Eric in a little while and really think about, sort of dozens upon dozens of implementation strategies. There are also multifaceted strategies, which is a combination of multiple of these discrete strategies, which we'll try to give you a method for thinking about which ones to select along the way. And then there are blended. And Dr. Madden is going to spend some time talking about, a very, very important blended strategy, which are multifaceted, that have been protocolized. They have a number of different processes within them. They have a sense of fidelity. Are you doing things in the way that you are? And in some ways, some of these sort of strategies, they've been subjected to sort of latent class analyses or factor analyses to identify which of the parts are going to give you the most bang for your buck. If you have certainly a blended strategy that has got 15 different elements, sometimes it's important to know which ones of them are most important. But it may be the case that you have to tailor what you're doing to a new context because you're not really, you haven't prioritized those particular elements that are together. And these are just some of the examples of some of the blended ones that are available today. And we're going to get to hear about one of them. One of the things that I'll just give you an example of a multifaceted strategy. This has got 11 components or discrete strategies. And we will get back to Eric, which are these 79. They've actually grown to 83. They're evolving as Byron Powell keeps sort of adding to this list. But here's one example of where they looked at, and to answer the question, can learning collaborative support implementation by rewiring professional networks? And the idea is that when we're in these professional settings, we work in a somewhat siloed sort of setting, and that if we interact and we collaborate with each other and spend more time learning from each other, can we actually change the way that we have practices? And in this particular study, the rewiring actually occurred through network analyses, and the learning information actually increased, and it actually improved implementation. And so they were looking at maybe 3 or 4 different ways to sort of think about how to change the learning within these sort of peer networks. One of them was using external experts. That's one way, at least, to provide education and training. Another one is from peers from, an alternative organization. And the third was to really take colleagues within the agency who provided social and professional support. And they went through a whole series of activities. They did the preparatory work. These are some of the elements of the strategies, such as preparing a change packet, getting people to make a commitment to doing this. I know that with some of my colleagues who are here, one of the sort of recent emails that we sort of addressed was, well, we've got all of these sites that are supposed to be working, but some of them just don't show up to the call. So making a commitment can be one of the really important parts of that. Having active learning sessions. It might be a single session, such as a workshop, or it could be a series of them that really build upon each other. Plan, do, study, act cycles. We're going to hear about some of that today. Some of the ways that you support people, conference calls, staying in touch. Those, in some ways, conference calls are kind of reminders, if you will, that you've got to do work. Having the availability of web support. These are all some of the discrete strategies that were within this particular blended strategy. Quality improvement treatment, looking at your work, doing the PDSA, having metrics reporting, knowing what your findings were. We're going to hear from Mona today about dashboards. You know, you had 50 patients that you did this with, and did you move to 60 the next month, or did you stay where you were, or you actually slid backwards a little bit? And then, of course, there are some enhanced features as part of this particular blended strategy, such as coaching calls, where there's facilitation that occurred, site visits by experts, having someone sort of look over your shoulder. That can, in some cases and studies, be positive, and in other cases, it can be very negative because somebody doesn't want Big Brother coming in. And then, of course, ongoing mentoring. Oh, here's a challenge that you had. This could be telementoring with Project Echo, for example, that has learning collaboratives. And what they did was they looked at all of these. They found that a few of them were much, much more important than others, but that each of them independently contributed. And so you needed a sort of a group of things to come together. And so just sort of saying that in some kind of settings where it's much more complex, you really want to work across many, many different levels of the socio-ecological model, that you may have to do things a little bit more broadly in order to get the outcome. Now, the opposite is true. You can actually work with a large blended model, and you can go backwards. You can actually break the pieces apart, and you can test one strategy versus another, and you can do it and see if there's a layering on effect. I think Jen will probably present on smart designs to some extent with one of the trials. You know, when people don't do well, what do you have to add on? Maybe perhaps you don't need everything that is there. One of the things that we learned around addiction treatment was, for many years from Cochrane reviews, we really believed so strongly that we needed all this additional psychological counseling. Well, the truth of the matter is we really don't need that much. We need it for about 15% of patients, but in systematic reviews, we don't really need all of these services. We probably need it for situations and places where we need that small incremental sort of boost. The expert recommendations for implementing change, or ERIC, that Luke brought on, really, at least in my mind, was very, very helpful. Now, it is huge. When you go to the paper and read through them, there's a lot of them out there, but this was a huge event. There were 132 experts who got together, and they went through a series of Delphi methods, and it's still going on in process. But really what they did was they gave us a taxonomy. They gave us a language. They gave us a way to group these implementation strategies, and they're growing. And we're using more and more different ways in order to get at that. And we saw this broken apart, but really came up with 9 clusters and 79 strategies. It's grown a little bit more, and they put them into discrete areas where you can think about how to actually do things differently than you were before, such as changing infrastructure, engaging the consumers so that they are part of the plan. That's oftentimes what happens with collaborative learning. Sometimes you need to utilize financial strategies. I think we're going to hear today about pay for performance, or when people attend things, do they get sort of reimbursed when they have to take away time from their work in order to do something? Is that sort of made up in other sorts of ways? Train and educate stakeholders. That is really one of the more common themes that goes across many of the different strategies. Having stakeholder interrelationships. For example, if you're going to integrate care, and we're going to spend a little bit of time going through some examples for healthcare integration, sort of thinking about how people learn from each other, adapting and tailoring to the context. You know, it is oftentimes the case when you go to a new place and they say, but that's not how we do things. Our laws are different. Our people are different. There's all of these other sorts of things. And so really understanding how you do some of that tailoring to a unique setting in order to overcome obstacles. And sometimes you don't recognize that you need to tailor your strategy into a new setting until you start going there and you don't get the change that you want. And so if your change is really minor, you reassess. That's why data is your friend. You reassess where you are. And if you're not getting to where you are, you need to do something different, which is oftentimes tailoring, or it may be adding on a new strategy. So here they are in the broad bucket. So using evaluative and iterative strategies, looking for readiness, assessing barriers and facilitators. And remember, as you implement and maybe you go up and you don't go up as fast as you want, you might need to reassess because you may have overcome a barrier that you wanted to achieve with one of your strategies, but you may need to supplement it or modify it or tailor it in order to keep moving in the direction that you're trying to go. Audit and feedback. Here's what you've done. Here are some potential strategies to move on. And I'm going to break those up because one of the things about these strategies is some of them are very intensive and some of them are very low barrier. And so you have to think about some of those things as you're making a decision on what you're doing. Adapting and tailoring to context, we'll spend a little bit more time about doing that. One of the things that often happens in many settings is people are very comfortable doing what they're doing. And many people also don't like change, but all of implementation science is changing what you're doing in order to get a different outcome. Training and educating stakeholders, as Luke said, and I've repeated that this is a common part of many of the various different strategies. Sometimes it can be a single training, it's something simple. Sometimes it requires repeated trainings and update, especially when people are learning new and complex skills. Let's say, for instance, if you're a non-specialist and you're beginning to learn about treating a new disease, and let's just say I'm a primary care doctor, and all of a sudden I'm now being asked to learn about HIV. People need to have perhaps ongoing training, and they need a way to have support when they get into trouble with their patients. Engaging consumers. What do you do in the case of increased demand? All of a sudden your implementation strategy says, wow, we've tested all of these patients and we're starting to bridge that gap, but we don't have the providers to take care of the 3,000 new patients that we have brought into care. So how do you engage consumers so that they are now part of that process, whether you use social media campaigns or other sorts of mass media? Some of the work that we're thinking about doing in some settings is using as a recruitment tool some of these social media ways. And these are sort of new ways to do something differently. If you think about HIV testing, we used to have a counselor. They often sat in an HIV clinic, and nobody's going to go to the HIV clinic to get tested, so they moved it out. Now they've moved it on to self-testing. They are doing a strategy differently than they were before in order to get a better outcome, because there will always be subpopulations of people who will actually respond to one strategy differently than another. So they're not typically going to all be universal. And then, of course, changing your infrastructure. This is a really hard thing to do. And one of the things, sometimes it takes time, and people keep saying, yeah, tomorrow we're going to change it. And you develop this level of inertia. So sometimes just implementing, even though you have a rigid infrastructure, your data, and I'm going to show you some findings tomorrow about how your data is your friend, and you can use that to advocate for changes in the way that you get funding or the way that the policies or the guidelines all sort of come together. Sometimes you have to change the physical environment, and there are settings where people just did not have the space. And I know that Lynn and I were recently in Peru, and this one guy said, I can't do the HIV treatment because I'm not sure if I've got a room on any one given day. Now, what's interesting is there are actually papers that suggest that just by starting somewhere and all of a sudden you've got a mass of patients that are available, they find a space for you. It might be a closet, but these sorts of things can sort themselves over time. And you don't have to fix every single problem with one strategy. You can sort of add on, and some of those sort of barriers that you've listed beforehand can go away. One of the more powerful strategies that's used in implementation science is interactive assistance. And of course, there can be some dynamics between who are the two interactors, who is the person, let's say a provider in the clinic, and who is the person who's giving the advice, and how is that advice given. Facilitation is one of the more powerful strategies that is used. Technical assistance is sort of bland. It sort of just says, all right, you can do this or you can do that. Facilitation often becomes organic, and we're going to have a whole presentation on facilitation or it could be clinical supervision to oversee the sort of work that's being done. Developing stakeholder interrelationships, especially whenever you have two different levels that are not communicating well with each other, bringing them together through a series of strategies, finding champions. We sometimes use the word early adopters, but it's really good to have a champion. It's also good to have somebody at the top, the executive sponsor, say, this is important. And so engaging your stakeholders early and getting someone at the top to be able to say, I want this to happen, so that the people below actually know that they have permission, right? So it's one thing to talk to the boss and say, yeah, I'd like that to happen. Asking them to tell their folks is a different story. And so that could be, part of that. And then in some cases, especially in low and middle income settings where people are sort of, underpaid, and they just at least believe that they can't do one more thing, even though they can. If they can do it faster, cheaper, and better, they can find space to be able to do additional work. There might need to be some financial incentives or bonuses. And we've learned that that's been a somewhat very important strategy, maybe perhaps in some low and middle income settings where people have very low pay and there's really not an incentive to do more than they're already doing at the present time. As Luke said, you really need to make sure that you understand what the barriers and facilitators are in order to select that. Oftentimes, the barriers are at multiple levels. The strategies don't always work as planned. And let me just sort of remind you, this is a slightly different version. For those of you who go on the web and you type in socio-ecological model, you're going to get a bunch of different pictures. And so here's one that's a little bit more expanded from Luke's, but you've got these policies, these guidelines, the laws in some sort of settings. You've got the communities and where people live and where perhaps health structures are located within a community, and how do people within the community actually feel about things. How is the organization working, and is the organization flexible and able to make changes as they come along? And then, of course, there are those interpersonal relationships. So if your target is to get a person on antiretroviral therapy, they have tons of relationships. They might have a spouse or a partner at home. They have a family who may or may not know about their HIV status, and there could be some non-disclosure sorts of concerns that are there. There are peers. There are a number of different relationships happen, but there's also the relationship that happens between the provider and the patient. And so understanding those multiple dynamics that are at play helps you in your decision in terms of what kinds of strategy that you do. So this is another one of those black boxes, selecting your strategy. Fortunately, the folks with the CFEAR group have really tried to help us think about using a deterministic, sort of framework in order to really put in our inputs. What are the barriers in a number of different situations, and how to actually, sort of select a strategy. Now, there are some very sophisticated and I would say complex methods that are not available to everyone in order to sort of look at this. Concept mapping is, by the way, all of these slides are going to be available, unless you want a picture of me, and then I'm usually going to get a lot of glare off my forehead. But concept mapping is one of the ways of sort of really defining what might be the way to sort of go about your approach. Group model building, advanced biostatistical methods. We've got Denise here who can sort of help us with that. Our team has had a fair amount of experience using conjoint analysis, sort of developing latent classes where things bundle together so that you can think about putting your strategies together. And then intervention mapping. I'm not going to go into a lot of detail, but this paper by Byron Powell really sort of sets these out. And this is these are some emerging fields. I would have to say a lot of people aren't using them very often, but there is some work that's being done. Now, Enola Proctor has really put together, you heard about these key names, Proctor, Damschroeder, Powell. These are a lot of the big names that are going to come up as first or last authors on a lot of the seminal papers. But one of the things that's really important, and it's really about making, and I think it's really helpful, not only for writing your papers up and developing your protocols and writing your grants, but it's really important to be specific. And especially so that you can report on what you actually did. So you sort of need to name it. What is the strategy that you're going to use? And ideally, if you can map that on to the ERIC criteria, it helps you put it into the right kinds of buckets. But then oftentimes, let's say training and education needs some kind of specificity. So define, we are going to train people with a 3-day training session, and we're going to give monthly, 20-minute sessions thereafter, so that you know that not only it is a single strategy that is linked to continuity of care, you can layer onto that by saying you're going to give specific feedback or clinical advice or telementoring through all of that. So you specify it, and you do that in a number of different ways. Who is the actor? So if you're going to have an expert opinion, who is that expert and to whom are they giving the advice? What is the action that they're going to be taking? What are the steps and the processes by which they're doing it? Who is the target? So you've got an actor and there's a target that have a relationship with each other, okay? And what if that relationship is antagonistic? Or what if it is very promoting? You might need to measure that over time. What is the relationship? We're doing some work with mentoring using Project Echo, which are these video teleconferences where you get a 20-minute didactic session and case presentations, see one, do one, teach one. But what if the people who are presenting the information are not presenting it in a way, or they're not interacting with the crowd in a way that's positive? And so some of the things that we're doing is we're looking at some of those dynamics, but you need to understand that there is a relationship between the actor and the target. When is it being done? And is it being done, at a different time period? All of a sudden you add that on. So are you going to learn as you go? You have to sort of build in some temporality with regard to either your analysis or the way that you do the sort of work? In other words, with some of the smart designs, which you're going to hear about, do you add on something at a later time point when something doesn't work? So is there a temporality to that? What is the dosing? If you have, let's say, a monthly session, how many people attend every month? How many people attend just once? How many people don't attend at all? Or do they attend the right sort of sessions? What is the implementation outcome that you're looking for? And can you justify why you are using that? And is it related back to the barrier that you've done? What I will sometimes hear early on is that people will say, gosh, I think it's a good idea to do this and that and that. And I say, well, why? Have you looked at the barriers yet? Well, no, but I just know from clinical practice it's a good idea. So having a way to sort of get to that can be really useful. Now, for those of you who like tools, I think that this is really exciting. You still have to, I think it through a little bit when you get the information back. But what Dan Schroeder and their group has done with the CFEAR framework, and they've got a beautiful website. You've got the list of barriers. There's 39, I think, different constructs. Do I have that number right? It's in that number. It's up there. There's a lot of them. But what you can do is you can go through that process of really doing that specification types of things earlier on, taking your barriers and inputting it in here. And I sort of circled the area where it says strategy design, because when you go to that website, you click on that particular middle toggle switch, and then you'll get to a site here. Well, they will basically, you'll put in your barriers and what your problems are, and it will help you with matching to the ERIC criteria, all right? So it's a useful tool. They won't always get it right, because you still have to make some other considerations once they sort of spit the output. It's kind of like, one of the things that we're learning with artificial intelligence, garbage in can be garbage out, right? So you really have to think about it, and sometimes you have to refine it, and you have to sort of rethink it, as you go through. And one of the things that I bring to the table as I'm thinking about these things is really balancing this notion of what is the intensity to the implementers and to the people, the actors, if you will. What does that intensity look like? And obviously, if you can get from point A to point B with a very cheap car, that may be good enough. You don't always need a Cadillac or a Mercedes to do that. And so you sort of need to think about that. So if you can do it more efficiently with sort of a lower intensity, that's great. Oftentimes these lower intensity interventions may not give you the bang that you'd like. So then you have to balance that with what is the efficacy of that particular strategy. And I'll show you some data that all strategies are not created equally. So you have to sort of think about that. So even when you want to even compare strategy A versus B, you might look at a low intensity strategy versus a high intensity strategy. And if you get an equal outcome between those two strategies, it's a clear decision to use the low intensity one. So you have to think about it in those sorts of ways. This is a really nice paper, and unfortunately I didn't put the citation in, but these are some examples of, actually I pulled them from a couple papers, but these are examples of tailoring strategies to the determinants, the barrier that's located. So if there happens to be a lack of knowledge, and let's just call the actors clinicians, interactive educational sessions might be one. It could be a single training. It could be sort of repeated trainings over time. If there's a perception reality mismatch, so in other words, the clinician says, I'm really good at what I do. We as clinicians always say that anyway. But I'm really good at what I do, and I do this perfectly, and I'm going to get a sort of a great outcome, and I don't need you to teach me. But you look at their results and you audit and you give them feedback. Oh, well, you've done 50% of, what we want. That's really good. How can we move that to 60 or 70%? So that is a perfect place where there's a mismatch between the perception and the reality. And that's why data is your friend. You need your data to guide some of what you're doing. Perhaps a lack of motivation, incentives, or sanctions. I'm not much of a sanction sort of guy, but they do work out there in some ways. Maybe in Russia they might work. I don't know. I shouldn't say that. Anyway, so there are those sorts of opportunities. So behavioral economics can be one of the strategies, pay for performance, that might work under those kinds of settings. Giving people time off, changing their work schedule so that it's more fluid. Those may be some of the sort of the incentives and sanctions that might be there. It doesn't necessarily have to be monetary. Some of the beliefs and attitudes, when I first started working on introducing methadone and buprenorphine in Ukraine exactly 20 years ago, I can tell you that everybody thought that I was the devil because they really hated the idea of this. And so it took a lot of peer influence and getting opinion leaders and training people to become experts and becoming the new champions before we ever got sort of the takeoff, if you will. So we had a handful, we had 8 sites when we started, and I have to tell you, it was like pulling teeth in order to get it started. But once we got a couple of champions going, it actually really worked well. And then, of course, there could be systems of care barriers, the way that it is designed. So redesigning the process, changing the way that you do your work, and oftentimes will make it easier and faster, and it reduces the demands on clinicians and on patients through doing that. Now, we oftentimes might have let's say, an audit and feedback sort of strategy, but tailoring it to the local context might be important. So in other words, if you have a Rick Altice who might be a good auditor to give feedback in one setting, these people over here may just think he's an absolute jerk, and that's not the right setting. So you may have to tailor what you do. You may have to tailor the frequency with which you do it. But there has been some equivocal outcomes with regard to tailoring. Tailoring does not universally mean that it gets better. It just means that you've done something differently and you're trying something differently. But it can be effective, and especially it means that you're doing something differently tomorrow than you were doing today. And these are data from a Cochrane systematic review. There's a couple of steps that are important for tailoring, sort of assess and understand the determinants. That's one of those words that goes back and forth. Just translate that to barriers within the local context, because it may be different in Georgia than it is in Ukraine. Identify and change your methods so that you can address those determinants. So if you're using an audit and feedback, change the way that you do the audit and feedback. And then choose strategies that use those methods that are directly specific. So if you're using that sort of Eric and Seafear tool, you want to make sure that there's a connection between those things. Sometimes people say, oh, let's do something different, and it has nothing related to the barrier, and you won't get the outcome that you're looking for. Now, this is where it has to do with what people feel might be important. So these are the factors. This is in a group of several hundred people who were sort of looking at what influences the selection of implementation strategies. And number one is the relevance. Does this strategy directly influence, and at least you've got, I didn't put in the category of not effective at all or not important at all, but essentially you get a really 85% who thinks it's extremely important to having a strategy that directly influences the barrier. Is it likely to result in an improvement opportunity? Will it make a big impact? In other words, will the smallest amount of work give you the biggest amount of impact? And so that was number two. And following just on the heels of that was, is it feasible? Can we realistically do that? If you put a Cadillac or a Mercedes intervention in a setting where there are huge time constraints and you can't get them to do it because there's no fidelity, you're not going to get a good outcome. Then you have a fairly big drop off, and the validity. So in other words, is it effective at working? Seems to be less important, as well as the level of difficulty. In other words, the work and the resource requirements. So a lot of times people will say, we don't have the space, we don't have the time, we don't have to do all of that. But once people get into the process where they are making things simpler for themselves and they find themselves to have more time, that becomes more important. But it doesn't have as much relevance up front with regard to the outcome. Here's a meta-analysis just for the effectiveness of implementation strategies and clinical practice guidelines. Now, this isn't for all implementation science. And what they found was, and there are other systematic reviews that says in general, audit and feedback will give you about a 4% benefit. It's something, it's statistically significant, but in this meta-analysis, it didn't really show an impact on processes, the things that you do, or on the patient, whether you're using a single or a multifaceted strategy. Changing the organizational culture, getting people to be motivated, having them see that the evidence-based practice work. One of the studies that we did, we introduced methadone, and you'll hear some data from Atiri, but on sort of implementing methadone in primary care clinics. And the people who were not doing the methadone thought it was the worst thing ever. Why would you bring those terrible people into my clinic? And what happened is that the people who got into methadone, they got dressed up. They looked nice when they came in, and they showed up to clinic every day, and it changed the culture because their stigma scores went down dramatically as it related to doing that. So the contact, doing the work, can actually have an effect on changing the organizational culture and the way that they do the things that they do. Educational interventions have got a mixed bag, really quite positive with regard to processes for both single and multifaceted strategy, but there's a handful of studies that show a negative effect. So it's mixed. So it matters what you do, how intensive it is for that particular population, and is it repeated? All right, so those are some of the factors when you think about that. Patient-directed interventions, once again, sort of mixed with regard to its outcome. If you add on more layers, it doesn't seem to have as much of an effect, and most of it's on the processes. Reminders, interestingly enough, and Mona will be talking about dashboards and reminders, they seem to be quite effective, certainly as a single intervention. I know as a clinician, if my dashboard comes up and says, oops, you haven't done this, even if I'm busy, I'll sometimes say, I need to figure out how to do that. Educational meetings in and of themselves did not have much of an impact across any of these domains. Information and communication technology. The communication technology, since this meta-analysis, the data only went up through 2000. It was published in 2022. The quality of the technology has gone up, so I think that we have to sort of keep our eyes open around this. And academic detailing, coming in and sort of saying, oh, gosh, you really didn't do this right. That doesn't seem to have much of an impact In other systematic reviews for other diseases, it does have an impact. So this is just for this one particular narrow area. But what I really wanted to point out is that whatever it is that you're doing and you're trying to implement, not everything is going to have a complete effect, and there may be sort of lower level versus higher level of efficacy. I'm almost done, thank goodness. Let me just do a couple of case examples. This is a systematic review looking at facilitated strategies for integrated care. And I bring this up because we've done a lot of work in this area, but it's the idea that you're trying to make two different stakeholders behave together. Our systems of funding are often separate. People believe that it's not their job. It's not my job. There's a whole bunch of stuff that goes into this. They pulled together 14 studies, and they were really trying to figure out what strategies contribute to improved integration for alcohol and other drug services, including behavioral health, and then what really sort of improves the overall outcomes for individuals and for organizations. And one of the things that they found generally, some of the major barriers, is that there's oftentimes serial treatment. You go into primary care and you get screened, but then there is a behavioral health issue that has to be addressed. And those two places are miles away in terms of mentality and the way the treatment is. Siloed healthcare delivery systems and lack of coordination between them, and lack of training and support for specialty training conditions. So if you happen to be in primary care and you're all of a sudden asked to do what is perceived to be specialty care, it may not be one of the things that people will adopt or take on. And if they have to screen, they may feel helpless because they don't have a system to which they can actually get them to in order to get treatment. So they say, why screen for it if I can't treat it? I remember years ago when it came to HIV, when we didn't have treatments and we were trying to get people tested, and we knew that people reduced their risk behavior just by knowing their diagnosis. But many people would say, why would I want to get treated if you're not going to do anything for me? You're just going to give me a bad diagnosis. So these are the realities of what happens under these kinds of settings. And so many of the strategies in these settings have targeted many levels, even at the organization and at the provider, and oftentimes in combination. So what I've sort of done here is I've used this sort of socio-ecological model because this is how, they didn't actually put it into this, but I happened to put their findings into these various different levels. And the first one was to take a look at that outer level. How is the funding sort of happening? So it's called system investment. And there's a couple of ways to do that. There's interdepartmental collaboration and co-funding of service delivery. And for each of these, I'm going to give one good example of what the barriers were and how they selected a strategy. In this systematic review of 14 papers, none of them dealt with the issue of administrative issues, executive sponsorship. I think it's often overlooked. I think we just do it organically, but nobody looked at how do you get the lead person to care about what it is and to share the information that they want to do something different. Organizationally, interagency agreements, sometimes that's just paper, so they don't have much of an effect, but at least it sort of makes people have a commitment that they're going to do something, even if indeed they're not getting coaching and support to actually do it. Goal setting that are common between the two agencies. Lynn and I have worked in the US about sort of strengthening systems of care for addiction treatment and for HIV. Really sort of a nightmare. People don't really come together easily around that, and co-location of services. And then of course, for service level delivery, staff training, information sharing, case management, referral services, professional networks were all part of the implementation strategies. And clinically, some screening practices, joint care planning, and team involvement and staff supervision. So at the system level, one of the best studies was done in California for Medicaid. And what they did was they had a law, they had a regulation that says we can't reimburse you for a same-day visit where you get a behavioral and a physical health appointment. Why would you screen someone if you can't get paid for it? And if you want them to get care today, the behavioral, let's say the physician in primary care will screen them, the behavioral health person doesn't want to see them that day. They don't get paid for it. So that is a system level thing. It has to do with funding. That is how people actually earn their keep. Am I going to do work for free today? There were some other things with same day billing that occurred for therapists. So it wasn't even just that they could get to a counselor. That also didn't get reimbursed. And then there was really sort of a lack of any kind of support services in the community. So they could do it at that clinic, but they couldn't do it elsewhere. Some of the strategies were to change the reimbursement strategy. Medi-Cal did that. They changed it and said that we will treat both of them. They actually increased the amount of clinicians who actually did the work. And then what the other thing did was they went to SAMHSA, which is our addiction treatment funding silo, and they increased the number of block grants to California through a co-investment from the state in order to come up with some benefits. Moving down the level, I'm going to choose co-location of services. There were federally qualified health centers, and they had a number of behavioral health people, mostly social workers, on site in their clinic who were able to work. Both of them could bill. And what happened was the social workers were providing some audit and feedback to the clinicians about sort of increasing screening, and they did that. And so the number of patients increased and referrals to behavioral health. So they had a positive impact on one effect, but there were secondary consequences that all of a sudden the social workers had a new caseload that was doubling. And they were like, how do I take care of my regular patients, my caseload, if you will, and deal with the new patients? The doctor says, you got to see this person now. I've got 15 patients waiting for me. How do you do that? And so there was also the primary care clinicians did not have the confidence to screen and treat alcohol and other use disorders. Some of the strategies that were deployed in 2 different studies was they supported the clinicians. So clinician support by essentially taking one social worker, and their Monday, for example, was the urgent visit day, and then they would switch them out. So they changed the way that they do this work so that they did not have time taken away from them in order to do this. Or you could actually have a time of the day that sort of work gets done. But they basically created role clarity. They clarified the role of what people were going to do on each day so that people knew what they had to do and they did not have different expectations to take on something new. Training and education, there were studies with both single trainings, which were less effective, and sort of repeated sessions using telementoring with Project Echo, which actually had a huge upscale in terms of the treatment that was available and the outcomes, and then audit and feedback in terms of whether people were screening and whether they were doing getting people on treatment. They'd created a cascade, and they found that those were the factors that were significantly improved outcomes. Information sharing for service delivery. Primary care physicians were unaware of how the patient is doing with behavioral health. Said, I diagnose this person, I send them over to treatment, but how are they doing? They're over there. They've got a different medical record. And the behavioral health people were unaware of what was going on medically. Their diabetes isn't controlled. I didn't know that. And some of the strategies were case conferences. They would limit it to 30 patients per week. They would get together. They would go through the ones that were the more complicated. They would prioritize them. And so essentially what they did was they did collaborative learning. These behavioral health folks said, I understand a lot more about diabetes now. And the people who were doing the primary care says, oh, I'm starting to get what this is. And they started shifting their service delivery so that they took care of the behavioral health. Other things that they can do is they can share notes. Now, this particular study was done before electronic medical records, but even for some places, behavioral health records are siloed, and not always, but from the sort of the general medical care. And the other way that they did is they would take their consultation note and they would share it with the opposite providers so that it went into both medical records at the same time. Screening and treatment at the clinical level, clinicians didn't feel comfortable screening and treating. Screening activities, they said, took too long. How am I going to do this if I have to really now go through alcohol, and now I have to go through other drugs, and I have to go through tobacco. I've got to go through depression. You've got 4 things that you have to get through. So what they did was they created tools, quick screening tools that made it faster, cheaper, and better, so that they didn't have to do these long diagnostic, I've lost my screen, but anyway, these long diagnostic sorts of things right up front. So they were basically given some tools in order to do that. Some places developed QR codes so that patients could do it in the clinic while they were waiting, and they could do it online, and then the feedback would come back so that they would have an output. They did a lot of training and task shifting so that sort of the physician was not doing it. They moved it to the time when they're doing the blood pressure. Oh, by the way, X, Y, and Z. You don't need a physician to do the screening. You need them to do the diagnosis. Creating simplified tools. There are now single item screening questions in order to do a lot of this stuff. And then they provided audit and feedback. So in summary, I think we need implementation strategies. There are still some black boxes out there related to implementation science, and getting the right combination together is a challenge. But we need better tools to align our barriers with our implementation strategies, and identifying where we need single strategies versus sort of complex or blended strategies. I don't know if I have time for questions. I ran over a little bit. I promised I would be on time, and I'm not. Thank you.
Thank you so much. I think you also, no, you enjoyed the lectures as much as I did. I was trying
I enjoyed it more than you did.
Oh, I doubt it. I was trying to apply all these strategies to Georgian mental health system, and especially introducing alternatives to coercion to our system. And I'm grateful because while I started thinking in well, with the new insights. Thank you so much. My dear friends, let's steal some time from our coffee break and perhaps ask the question.
And if we're running short, I'm not running away. I'm going to be here for 3 days. You can ask me on the side, so don't hesitate.
But, oh, Marco, yes, please, introduce yourself, please.
I'll repeat the question if you're not loud.
So my name is Marina Marco. I'm an epidemiologist working at National Center for Disease Control and Public Health. I work in Health Promotion and Communication Unit. My question was how much the implementation science should be the part of the general practice of public health specialists in the working in the like national agencies, and the second question following this is how can we institutionalize the implementation science in the agencies like us, because it follows with a third question, how they allocate the resources and funds, not just the international agency, etc., but the local funds to invest in implementation science and show them.
So the short answer is yes, yes, and yes. So I think, as Luke said, even at the time point of getting, an innovation that's coming to the mark, these hybrid trials, and we'll hear a little bit about them, we really do need to understand those implementation factors. And your stakeholder, the national, CDC, that is really about public health. It's not just about individual health. And so implementation science is exactly where the work has to be done. You set up the clinics and people have to come and they show up, and you're not getting the outcomes that you want. So if you want to control disease control, you're going to have to do implementation to influence screening, evaluation, treatment, and probably retention for any of the diseases that you're looking to sort of control. So I think it really is where the movement is. And that's one of the reasons why we got funded to do this, is because that's what's needed today. And then the fourth part is about the resources. If you demonstrate, you keep your numbers, and don't just keep pulling in numbers from folks, do something and study it. Denise is going to teach you about interrupted time series. You did this, you got that. There are ways to do some of this. Then you show that there's a need for it. We did this and we got that. But I will also say that oftentimes the existing resources that you have can be used in order to create efficiencies in your system. And if you can create efficiencies, you may not need huge amounts of other resources. So that's what I call a freebie. And I'm going to present some data on where people found all kinds of time by changing what they did, and they actually improved health outcomes. So you'll hear about that tomorrow if you're back. All right. Thank you so much. I appreciate it.